Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features answers from a panel of international lung cancer experts to clinician questions about the management of MET exon 14 mutation-positive advanced non-small cell lung cancer. This episode is part of a larger educational program titled MET Inhibition in Advanced Non-Small Cell Lung Cancer, Molecular Targeting for MET exon 14 and Emerging Options. During this podcast, Dr. Luis Paz-Ares from University Hospital 12 de Octubre in Madrid, Dr. Ross Camidge from the University of Colorado Cancer Center in Aurora, and Dr. Karen Reckamp from Cedars-Sinai in Los Angeles will answer questions asked by the audience during a live webinar covering a variety of important topics such as incorporating MET exon 14 testing into standard of care, a comparison of RNA-based and DNA-based next-generation sequencing platforms, regulatory and clinical differences between new selective MET inhibitors, and counseling patients on management of peripheral edema, a class effect with selective MET inhibitor therapy. For more information on the experts, along with a link to the complete program, including a downloadable slide set, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Welcome to this activity on MET inhibition in advanced non-small cell lung cancer. And I'm really happy that we are with us today. And we have an excellent faculty here. For you, what is the more sensitive testing assay in this setting? Ross or Karen, would you like to make any comment?
Sure. I think what we're starting to have to realize is that next generation sequencing is not a uniform test. It's a platform with lots of variability within it. Which primers do you use? How many genes do you have? Which genes do you have? And what is your source material? The reason that RNA is more sensitive is you don't need to know what the mutation is. You're looking for the end result, which is that exon 14 is missing. And I think there's a certain iniquity with the DNA because you'll pick up some MET exon 14s, and so you'll go, my assay's great. Look, I found one last week. But you don't know that you're missing nearly 50% of the possible cases. And that's what all of the RNA assays do. So I think as a clinician, you need to be able to go to your NGS vendor and start to learn the questions you have to ask about not just, I don't care if you got 10 genes or 50 genes or 500 genes. What are the genes? What is the source material? And are you picking up what I want you to pick up?
And I would agree with that.
So, for example, if you're getting a patient for a second consultation and had an NGS test based on DNA, and is not having some tissue left, would you go for a cell-free DNA testing, or would you rely on the NGS, the DNA NGS-based test that had been done on the other institution? What would you do?
Karen, do you want to take that one?
Yes, so I think that we've seen this before, even in just the era of EGFR, where a negative test is not definitive. And so I think you push forward, whether it means doing another biopsy, potentially a liquid biopsy, which is really valuable in these patients, to try and get a clear answer and understand if the incorrect platform was done or if it wasn't testing sufficiently for MET exon 14, that there's a large possibility that we're missing the potential for our patients, and now we have approved drugs, and so we need to make sure that the panels accurately are detecting these mutations, and we need to not accept panels that don't.
Yeah, I mean, I had an example the other day where Foundation Medicine has unfortunately, I think, tweaked the way they present data, and their headline says something like, no actionable changes with an FDA-approved companion diagnostic. And if that's the only line you read, you can get misled. So, in May 2020, we have had 7 different FDA approvals. And if that hasn't kept up to date, MET could be sitting underneath it. RET could be sitting underneath it. EGFR exon 20 or HER2 exon 20 could be sitting underneath that. And if you don't look down into the details, you simply writing in your notes, no actionable change, you will be doing your patients a disservice.
We got a question here which is from Dr. Lee, asking, how common are RNA-based NGS testing in the US and in other key geographic areas? I mean, if I'm taking from the European side, I could say that it depends on the country, and it depends if it's NHS-based or a private-based hospital. I don't think more than 30 to 40% of the patients will have access to RNA-based NGS testing. Very often, when they do NGS, they only do DNA, and that is something that we have to solve into the future. I don't know how things are in US.
So, I mean, there are in-house assays, and so, for example, the Archer DX panel recently was approved as the companion diagnostic for tepotinib in Japan. So there are commercial RNA-based assays which are going to be accessible. Unfortunately, Foundation Medicine currently is not an RNA-based assay, which is, you know, one of the big names. I think Caris may have an RNA-based extraction within it. Karen, do you know more?
Right, Caris definitely has an RNA base, and it really depends on the platform. I think a lot of us rely on our in-house, and it's I think that it's probably quite confusing to a lot of the clinicians that are out in practice who may not be seeing lung cancer all the time, and so really understanding those platforms and what you're ordering when you're testing is incredibly important, and today more than ever.
Okay, thank you. One is actually related to the side effects, and it's asking, is Dr. Peter Manolakis, for any reason, is there any reason why edema rates are lower with TKIs such as almolitinib in combination with osimertinib in patients with EGFR mutated tumors as compared to single-agent TKI MET inhibitor, treatment of MET exon 14 skipping EGFR wild-type patients? So it's asking why edema is lower in combination with osimertinib as compared to single-agent. Do you have any taking on that?
I mean, I think the data is, there's limited data for the EGFR and savolitinib, so it's small numbers of patients. I think it's very much a class effect that we see the peripheral edema. There may be something going on that by giving both drugs together that you may reduce that some, and it's not as noticeable. But I think it's still likely that the peripheral edema is something that we're going to see more in these patients as more patients are treated.
I mean, I fully agree. Likely to be also a reporting effect on a small number of patients more than any other thing. Okay, so the first question is maybe related to the difference in the adverse event profile and efficacy between type 1 and type 2 MET inhibitors. I don't know which of you would like to take it.
So Karen, you've done cabozantinib studies. You might be able to comment on this better than me.
The type 2 inhibitors tend to be more dirty drugs and cover a significant larger number of kinases. And so the toxicity with type 2 drugs tend to overlap with some of the VEGF toxicity and RET toxicity. And so hypertension, proteinuria, you start to see with those drugs. And the type 1 inhibitors tend to be more selective. And so really you start to see the peripheral edema as really the prominent toxicity, and some of the lab abnormalities that we've discussed in GI toxicities. But the fact that this type 2 inhibitors cover multiple kinases, you get the off-target effects. And it depends on which kinases it it is attacking more, but drugs like cabmatinib have significant toxicity, very difficult to tolerate. Things like diarrhea, hand-foot syndrome also occur with drugs like cabmatinib. So quite different, and the type 2 drugs tend to have more toxicities, but I think cabmatinib is one of the drugs with more profound toxicities.
I don't know if you have any experience with some of the other type 2 inhibitors. I fully agree with you, Karen. I mean, cabmatinib, it's really difficult to keep the dosing. You always have to dose reduce after a while. You're getting, some significant GI, hand-foot, sometimes hypertension. But it's not, you have to dose reduce very often. I don't know if I never use any of the other type 2 inhibitors. Do you have any experience at all?
Very limited.
Yeah. I wonder if, they went quiet because, the type 1 inhibitors were clearly going to be the best tolerated things to go forward to, but they, some of them may need to come back and be, re-explored.
Yeah. So, anyway, it would be really important to optimize the use, because one may predict that at the time of resistance, some of these type 2 inhibitors are going to be somehow the way to go, right?
Well, you can also use the antibodies. That's it's a small data set, but that's Symphogen 015.
Yeah.
Remember that this isn't activated by mutations that turn on the kinase domain. They activate by increasing expression of the protein that then sort of auto-aggregates and auto-stimulates. So it's the perfect thing for depopulating with an antibody.
Okay. So there is another question based on, concerning the MET-amplified tumors. And the question is, given the results with capmatinib, do you think it's enough to really treat our patients with capmatinib in MET-amplified tumors?
I can certainly comment on that. So I think the answer is yes. I think it's more complex because MET amplification is this continuous variable that can also be measured in different ways. And whilst the data suggests that you really need to be at the high end of MET amplification and ideally with true amplification, so not high polysomy, my worry is, although the capmatinib, I think, used an appropriate, at least for NGS, high cut point of gene copy number of greater than or equal to 10, if your next generation sequencing report just says MET amplified and doesn't tell you that level of detail, people will be being inappropriately treated.
So you have this patient which is, let's say, more than 15 copy number gains, but the patient is PD-L1 positive, let's say 55% of the cells. What would you do? Would you go for pembrolizumab? Would you go for capmatinib?
Probably I'd go for capmatinib, I have to be honest. I think the other thing I'd bear in mind is whether the patient was a smoker or a never smoker. If they were a never smoker, I'd absolutely do that because I'd be worried the PD-L1 would be a misleading reading. The trouble is the MET amplified are also often high smokers too.
Okay. So there is another question here, I think from Spain. So I'm going to take it.
Is it in Spanish?
What is the best technique to detect MET copy gain or amplification? And I think we just very much mentioned that. And for particularly, so what is your take in on that, Ross? Would you go for in tissue? Would you go for fish? Would you go for NGS technology? What do you prefer?
So honestly, it is the last remaining fish test that we still have kept on here. Even though we have a DNA and RNA-based NGS panel, we still use MET fish because it's the best way of truly quantifying it relative to the centromere. And, in the hands of a skilled cytogeneticist, they can also very clearly pick out, what's the tumor as opposed to anything else.
Yeah. So it's still nice that those data, particularly with cell-free DNA, is providing us some relevant information, particularly when you're not having access to left tumor biopsy, or particularly you don't have the fish assay around. So I think it's still a good addition to have. There is a question on the way you actually make recommendations for your patients in terms of counseling when you're giving capmatinib or tepotinib. Any advice, for example, on managing peripheral edema? So how would you do, both of you? What do you recommend to your patients, and how you specifically manage edema?
Well, so one of the key things is you have to tell the patient that they should get into the habit of weighing themselves and tracking an increase in weight, because it's not a classic gravity dependent edema always, and sometimes people just sort of gradually increase. I mean, you can get facial edema, you can get the back of one hand. To some extent, it can come and go, but there is a cumulative increase, and it tends to be a later onset side effect, but it is cumulative. You can improve matters with support hose, lifting the foot of the bed, and diuretics work a little bit, but it can be problematic. It's a harder edema. It's not just the sort of same squishy fluid accumulation edema, at least in my experience.
Yeah, we've sent patients to kind of peripheral edema therapy, like we send breast cancer patients, and doing that early on when the edema seems to be a problem can be incredibly helpful.
I must say I have the same experience with a couple of patients that had really tough issues with that, and the edema clinic helped them quite a lot. So I just got here a very easy question for both of you. What are the differences between tepotinib and capmatinib? Tell us.
Well, capmatinib has a license and tepotinib doesn't, unless you're in Japan. I think, it's hard, because when you start to look at efficacy endpoints, my concern is that we're not always comparing like with like, that there's some fundamental heterogeneity in this population. And the only thing that I feel comfortable, so, your PFS could be different, your response rate could be different depending on who exactly is in there. Now, this is kind of fuzzy science, but if you say those who respond have kind of identified themselves as the true MET addicted, then the only thing you could actually compare between studies at this point is actually the duration of response. That's also hampered by how long have you followed the patient up and how frequently you're looking. But on the basis of that, actually, tepotinib has the longest duration of response, which is kind of intriguing, but that's a little fuzzy at present.
Yeah.
And I think one differentiator is that tepotinib has data with liquid biopsy, which not that we would expect this to necessarily be different, but they were able to accumulate that data and present that data to show that it's similar.
I fully agree. That is the more relevant piece of differentiation, because, at the end of the day, particularly there is still a good number of patients that we identify based on liquid biopsy, because we don't have enough tissue to do the test at the time we're receiving the patient. So I think that's a very important issue.
But I would imagine that's transferable between drugs. That's
right.
I think most likely.
Yeah. So there is a question about would you use a MET inhibitor with PD-L1 inhibitor in a case that both tests are positive, MET skip mutation and PD-L1? Is that something which has any science behind, or?
I would feel uncomfortable with that, in the sense they don't necessarily combine terribly well. And also because of a concern that in particularly a never smoker who has high PD-L1 in the setting of a driver oncogene, that doesn't mean that's secondary to infiltrating lymphocytes. It could be downstream of the oncogene. And I definitely remember a patient of mine who was MET exon 14 skip mutant, was a never smoker, had PD-L1 of 90%. And she said, you have to put me on immunotherapy. And she just completely blew through it. Her cancer just went bananas.
All right.
And the other issue, we've tried that with crizotinib, and liver function tests went through the roof. So then the problem becomes that you aren't able to continue on the TKI therapy and you have to stop the targeted therapy or lower the dose of the targeted therapy. So at this point, we haven't effectively given targeted therapies with IOs or shown the benefit of that. I'm sure the trial will occur, though.
So tell me, what do you do with a patient which is, let's say, first line, is having a exon 14 skipping mutation? You put the patient into a trial with tepotinib or capmatinib or on a standard of care, and after progression, what would you do with this patient if you're not having any other clinical trial option for that patient? What would be your first option on progression to the initial TKI?
So I think looking for types of resistance would be helpful, and potentially thinking about something like cabozantinib, moving forward with one of our many immunotherapy-based options now that we have a large number available to us. And then obviously I like the ability to move to a clinical trial and potentially with one of the antibodies.
So I'd be a little different. So I totally agree with it. In an ideal world, you rebiopsy, see if you had an on-target resistance mutation, and see if you could, jerry-rig something with a class 2 inhibitor. And I like the idea of clinical trials, but I would probably put them on carboplatin pemetrexed. I don't even know that I would even include the immunotherapy. I might want to keep the TKI going with the chemotherapy.
So actually, honestly, I maybe would treat this patient with chemo-IO if the patient is not having any, let's say, specific genomic aberration I have to target. But chemo-IO would be likely to be my choice. I mean, at the present time, I don't have any reason not to give standard of care to this patient, let's say.
And Ross, even a patient in their 80s, you would give them TKI and chemo?
Yeah, the TKI is combined fine with chemo a lot. I think the issues are, there's some nitty gritty here. So one, we actually don't have any evidence of chemo IO in exon 14. They were presumably in the studies, but we don't know how they did. Yeah. And secondly, because of the combinability of IO and TKI, you'd probably have to stop the TKI. And you can think, well, why would you worry about stopping the TKI? Because we tend to see acquired resistance happening in a clonal fashion. So some clones are still being suppressed. And also, particularly for capmatinib, maybe it's also protecting the brain. So we're all kind of data free, but those would be my biases.
Okay. So, what do you recommend for people in terms of testing? That is a very relevant issue, that many patients are actually not being tested for many molecular aberrations, particularly for those which are not that frequent. So if you go to let's say a new center, so how would you try to make sure that all your patients in your center and in your network are actually being tested for exon 14 mutation?
I think it's similar to what has been done in breast cancer. When you have therapies and you need to get testing, you need to make sure that the centers are doing the appropriate testing. I think the issues we have in the United States is that there are many centers, many different pathology labs that are getting these tissue. And so it's not a simple algorithm. When we're in a bigger center, we can control that and make sure that RNA-based NGS testing is being done with appropriate amplification if that's necessary. But it is a little bit more of a logistic challenge, but I think we're all trying to address it. And as we have affiliate sites associated with our practices, we are working to try and make sure our lung cancers are tested in a more uniform way.
Okay, I got a very final question for Dr. Camidge.
Okay.
He's always trying to make people thinking about what are the difference between PFS and duration of responses. So people is wondering why were you somehow concerned about the difference in that specific case between PFS and duration of response. Could you provide explanation of the difference?
Okay, so if you look like EGFR mutants and you put them on an EGFR TKI, the PFS and the duration of response are almost exactly identical. I.e., if you have shrinkage but it doesn't quite manifest as a resist response, you're still deriving the same degree of benefit. When you get a disconnect, so let's take IO as a great example. Your duration of response is 2 years, but your PFS is 2 months. And that's not because of pseudo progression. That's because most people are actually not benefiting from the drug in an unselected population. So a disconnect between PFS and duration of response tells you that you have a group of people who are not deriving the same degree of benefit as the responders. And that plus the response rate running about 50% tells me that MET exon 14 still remains a molecularly heterogeneous population, and all of those data sets, we've now got 4 or 5 of them showing some people don't even express MET protein, some have other driver oncogenes, again supports that. So we are at the beginning of defining the true MET exon 14 addicted population.
So I just really like to thank you all, Ross and Karen, and finally I really like to thank the audience.
Thank you very much, Dr. Paz-Ares, Dr. Camidge, and Dr. Reckamp, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, MET inhibition in advanced non-small cell lung cancer, molecular testing for MET exon 14 and emerging options, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.